What is appropriate prescribing? Appropriate prescribing depends on consideration of several values: patient preferences, most up-to-date evidence, and clinical judgment. Some of the factors that make up prescribing in the elderly a challenge that most clinical evidence studies exclude elderly patients. They lack of goals of care, and there will be an accumulating comorbidity in this group of patients. There will be also a financial, traditional, and social factors affecting this mechanism. Appropriate prescribing can be assessed through different measures, but they can mainly be assessed by explicit measures, which is criterion-based, or implicit measures, such as judgment-based. The explicit measures are developed from consensus guidelines. They depend and rely on expert opinions and reviews. The guidelines commonly rely on highest end of evidence pyramids, such as published meta-analysis and randomized controlled trials. The approach with these measures are either drug-oriented or disease-oriented, and this can be applied with little or no clinical judgment. Limitation of this approach include not accounting for burden of comorbid diseases, not accounting for patient preferences, and expert opinion guidelines tend to lack evidence of validity and reliability. What about the implicit measures? They are inferring and generalization using information from the patient and published work to make judgment about appropriatenesses. It's patient-centered rather than drugs or disease-centered, and this approach will involve more sensitive data and account for patients' preferences. Limitations are highly variable and depends on providers' cumulative knowledge and attitudes, and also they lack reproducibility and reliability. Dr. Beers was the first medical student to do a geriatric elective at Harvard's new division on aging. He finished his geriatric fellowship from Harvard, and he was a faculty at UCLA and Rand. He is very known about his Beers criteria, which is an expert consensus set developed initially in 1991 to target nursing home residents. It's used to assess inappropriate drug prescribing, and it is the most widely cited criteria in the medical literature. It was revised in 1997, 2003, 2012, and recently in 2015. The criteria includes 53 medications designated in one of three categories. The first category, medication that always need to be avoided. Category number 2, potentially inappropriate in older patients with particular health conditions or syndromes. And category number 3, that they can be used, but they can be used only with caution. The criteria is completely available at the American Geriatric Society website for anybody who wants to learn more about it. In Beers criteria, potential inappropriate medications include medications that have limited effectiveness in older adults, are associated with poor outcome, such as delirium, gastrointestinal bleeding, and falls, and they have safer alternative available. When studying level of evidence, the drugs that have been associated with high side effect and they strongly need to be avoided are anticholinergic, tricyclic antidepressant medications, benzodiazepine, chloropropamide glyburide, and ketorolac. These drugs were associated with high level of evidence to avoid using them. Medication with moderate level of evidence are anti-Parkinson's medications, nitrofurantoin, alpha blocker, digoxin, megestrol, insulin, metoclopramide, non-COX, non-steroidal anti-inflammatory medication, such as indomethacin, and skeletal muscle relaxant. Do we have other criteria apart from beers? Yes. We have the STOP criteria, which is the screening tool of older people's potentially inappropriate prescriptions. And this is usually encounter drug-to-drug interactions, drug-disease interactions, drugs would adversely affect older patients at a risk of falls, and duplicate drug classes. They are arranged according to relevant physiological systems, and each criterion is accompanied by a concise explanation as to why the prescription is potentially inappropriate. What is the limitation of STOP criteria? Clinical guideline, which is used not to replace expert knowledge. They require regular updating. They lack pharmacoeconomic models, and they lack long-term patient outcome. It is always important to use what's called medication appropriateness index. And by this index, there are 10 questions that everybody of us need to ask themselves before prescribing medication in the elderly group. Number 1, is there an indication for the drug? Number 2, is the medication effective for the condition? Number 3, is the dosage correct? Number 4, are the directions correct? Number 5, are the directions practical? Number 6, are there clinically significant drug-to-drug interactions? Number 7, are there clinically significant drug-to-disease or condition interactions? Number 8, is there unnecessary duplication with other drugs? Number 9, is the duration of therapy acceptable? And lastly, is this drug the least expensive alternative compared with other of equal usefulness?